visible?
Yes.
So basically this is a thing on optimizing resuscitation and the critically ill. So for a start, we would go back to a bit of history. Sir David Patten Cuthbertson served on the Royal Scot Fusiliers, musketeers, during the First World War. And that was the time that he used muskets, you know, the front-loading muskets. You poured in gunpowder, rammed it in, and then you put in the lead ball, and needed a flint. So firing a rifle was a lot more difficult at that point in time. He truncated his education as a doctor, but he rejoined after he finished serving as a musketeer during the First World War, passed out as a doctor from the University of Glasgow. Why do we need to remember Sir David? We need to remember Sir David because he was the chap who told us about the ebb and flow of the phases of trauma. He described the first two, the ebb and the flow, which meant basically he described the ebb which lasted for less than 24 hours. And the role was the maintenance of blood volumes, catecholamines surged, you had a decreased basal metabolic rate, decreased temperature, decreased oxygen consumption with vasoconstriction, increased cardiac output, increased heart rate, and acute phase proteins. And the hormones that surged were catechol, cortisol, aldosterone. He was the first time, you know, imagine describing this during the First World War. He also described the flow phase, the catabolic phase, which lasted 3 to 10 days. And he saw plenty of his friends being shot during the First World War. So he had an actual role in, you know, diagnosing this and being able to set this up. And he said that the catabolic phase was all about maintenance of energy. And here you had an increased basal metabolic rate, the temperature increased oxygen consumption, negative nitrogen balance. And while you had an increased insulin, you also had an increased glucagon, cortisol, catecholamines. But because of these high glucagon, cortisol, and catecholamine, you had an insulin resistance. It was Moore who described the anabolic phase, which lasted from 10 to 16 days, 60 days. So you had less than 24 hours, the ebb phase. The flow phase lasted as a catabolic phase for 3 to 10 days, and an anabolic from 10 to 16 days. Now, that was a simplistic view. In some people, the catabolic phase lasted fair longer, you know, burns, pancreatitis, severe pancreatitis. It lasted a while longer. These were early days, remember. So in an anabolic phase, you had replacement of lost tissue. You had a positive nitrogen balance, growth hormones, and growth factor. And tissue growth factor were the people who, the hormones that powered this. But this was the basic. And I think if you remember that this was the base, a lot of help would come understanding the separate physiology. And we've actually advanced quite a bit. So what we've advanced through is to put in the timing. And we know that the following things work. What happens, I think it's very important to see the timing. The timing goes thus. I mean, you have movements in seconds and minutes, hours, days, and weeks. So you first had the sympathetic nervous system with the adrenergic receptors, adrenal medulla, and the stressor was the brain. You had which worked in seconds and minutes. In hours, you had the hypothalamic pituitary axis, ACTH, TSH, GH, FSN, LH, the renin-angiotensin mechanism, all of that's kicked in within hours. Within days, you had the inflammation and the immune system, the cytokines and the mediators. And I think with the COVID situation, some of you are having a hands-on experience to a lot of this. And in weeks, the behavioral changes happen. So correspondingly, the change occurred in the ebb and the two phases of flow, the catabolic and the anabolic stage also. And that explained a lot of the changes that took place during the ebb and the flow phases, both through catabolism and of anabolism. The pathophysiology of stress, if you had a stressor, the trauma affected the brain, and you had an epinephrine, norepinephrine sympathetic drive. But we realized that there were also other mediators. You had cytokines. It switched to T cell phenotype. Inflammatory mediators came on. The fat adipokines, which worked on resistance to anabolic syndromes. You had GI tract hormones also resistant to anabolic syndrome. And the net result of the brain, the cytokines, the adipokines, and the GI tract hormones was an uncontrolled catabolism A and a resistant to anabolic syndromes. And as a result of both these major things, uncontrolled catabolism on one hand and resistance to anabolic syndrome. So you induced catabolism and you didn't allow the patient to put on protein. So resistant to anabolic syndrome. And the combination of both of this was the energy expenditure and the substrate use, and I'll come to that. And there was a change in body composition. So first, let's look at the fluid resuscitation. Fluid replacement. So we are going to talk of the amount of fluids and the type of fluids, crystalloids, colloids, and bloods. So let's go to the next phase which told you that what amount of fluid resuscitation is needed. You had basically 4 phases. You had a rescue phase, you had an optimization phase, you had a stabilization phase, and you had to have a de-escalation phase. See, when you have a patient coming in severe stress, you had a rescue phase where you had to push in a huge amount of fluid. You optimize that. That was the phase of optimization. And during rescue, as I will later show you, urine output was important, but not that important. It became very important when you were trying to optimize the fluid. The important thing was, it was also equally important when you were stabilizing it. But the net result, you will realize that some of our patients in ICU, come in with huge amount of edema of the hands and feet, because we haven't gone in for the de-escalation. And that is an important thing to realize. I mean, all of you have had critical patients in ICU. You've seen them, and after a phase in time, you say, "Oh, her hands are swollen, her feet are swollen," because we haven't de-escalated the fluid. That is a very important modality that we tend to forget. Now, I'm going to go into a bit more of details during these 4 phases. So remember, rescue, optimization, stabilization, and de-escalation. The first 2 rows are going to stay the same, and I'm going to give you 2 slides, one after the other. So the principles, the first 3 actually will stay the same. Principle is life-saving, optimization is organ rescue, stabilization is organ support, and de-escalation meant just that, de-escalation. So please remember that the principles in rescue was life-saving. Optimization, you tried to save various organs and various systems in the body. In stabilization, you had to support them, and you went in for de-escalation. So the goals were, in the rescue phase, you corrected shock. In optimization phase, you optimized and maintained tissue perfusion. Stabilization, this is very important. You aim for a 0 or a negative fluid balance, and we rarely ever do that. And de-escalation phase was the time that the body is trying to mobilize accumulated interstitial fluid, and it doesn't help to overhydrate them. So that was the major problem that I think most of us had a major problem in the understanding. The timing was, rescue phase lasted within minutes, optimization phase in hours, stabilization took days, and de-escalation often weeks. Now, the next 3 columns are going to change. So phenotype is severe shock, optimization is unstable patient. In a stabilization phase, you had a stable patient, and a de-escalation, you had a recovering patient. So what was the fluid therapy? In rescue, you had to give rapid boluses. It's life-saving, after all. You had to give very rapid boluses. In optimization, here was where you titrated the fluid. Your urine output was important, for example. You titrate fluid infusion and conservative use of fluid challenges. In a stabilization phase, only minimal fluid maintenance. Intravenous only and only if oral intake was inadequate. And de-escalation, by all means, just stay on oral intake. And the typical clinical scenario in a rescue was septic shock and burns, for example. In optimization, intraoperative goal-directed therapy, your anesthetist would actually do that. Sometimes what happens is you're doing a laparotomy, a major laparotomy, and your abdomen is open for 5 hours. There's going to be a huge amount of loss in evaporation, which often the anesthetist don't look after. Also in burns and in diabetic ketoacidosis. Stabilization, nil per oral patient in post-op patients where you've done a Whippers and this patient is, unfortunately, you can't give the patient oral fluids. So you have to maintain him or her on intravenous fluids, and you have to be absolutely specific at trying to maintain a zero negative balance or a negative balance. And on pancreatitis, obviously on drip and suck. On a de-escalation phase, patients on full enteral, note the word, enteral feeding in the recovery phase of clinical illness. Now, as I said, the first three rows are not going to change. So in rescue phase, what are the hemodynamic targets? Autoregulatory thresholds of perfusion pressure. In an optimization, macro and microcirculatory blood flow parameters, because you want to look after all the organs. You want to ensure that the blood flow to the kidney, to the liver, to the lungs, and to the heart was absolutely fine. And above all, don't forget that blood flow to the brain had to be perfect. Stabilization, weaning of vasopressors with stable hemodynamic conditions, and de-escalation was returned to pre-morbid chronic values of pressure and flow. I mean, return to the original state. The patient was before the patient had trauma. The treatment options were in rescue, as I said, rapid boluses together with vasopressors, but you couldn't use vasopressors without giving rapid boluses. You had to fill the patient up. For vasopressors to work, you had to have fluid or blood in your circulation. If you didn't have that, there's no sense in giving vasopressors. In optimization phase, here was where you gave rapid boluses together with vasopressors and inotropes. In stabilization, minimal fluid maintenance. Again, as I said, intravenous only if oral inadequate and decreased support. De-escalation, you might actually need to use diuretics. Some of your patients you'll notice in the ICU or being treated for, post-Whippers or post-major GI surgery, the patient becomes extremely edematous, wondering what's going on. You've actually managed to over-transfuse them. So please be careful. So how do you monitor fluid replacement? Blood pressure, universally used throughout all the 4 phases. Heart rate remains the very important parameter. If the patient has a heart rate of 120 versus a patient having a heart rate of, let's say, 90, the patient who has a heart rate of 120 needs fluids. So please, blood pressure, heart rate, throughout all the phases: rescue, optimization, stabilization, and de-escalation. Investigation, lactate, through all the 4 stages: rescue, optimization, stabilization, and de-escalation. Arterial blood gas, also in all the 4 phases. Pulse volume and capillary refill in all the 4 phases. Altered mental status, very important only for rescue, and after that it is less valid because you have used it. You're going to give the patient plenty of, perhaps the patient is in pain, you've given fairly of narcotics, so it's going to be difficult to assess it. Now, this is the interesting bit. If you're in a rescue, you're just trying to get the blood pressure up, the heart rate down, and lactate and ABG and pulse volume corrected. Urine volume, the famous volume that we use, 30 to 50 ml per hour per hour, that becomes very valid only after you've crossed the rescue phase. So it becomes very important in the last 3 phases: optimization, stabilization, and de-escalation. So also in fluid balance. Okay, so fluid balance out here, in the rescue phase, and the urine output isn't so important because you're trying to actually save the patient. But optimization, stabilization, and de-escalation, it becomes extremely important. Continuing with the same thing, echo Doppler, rescue and optimization. And you know what you actually see with the echo Doppler? You see the inferior vena cava filling. And that is a very good monitor, but you need a very good ultrasonologist who can actually show you the inferior vena through the epigastric window, that you can see the inferior vena cava filling. So rescue and optimization is the phase that actually, this is an invaluable tool. If you have a dry, collapsed inferior vena cava, you still have a liberty of pushing in more fluids. So remember that inferior vena cava filling with an echo Doppler is a very invaluably valuable. It's an incredible tool that one can use during the first two phases. It becomes less important, can be used in stabilization and de-escalation, but far more important in the rescue and the optimization stage. CVP monitoring, because the most important is in optimization, less so in the rescue, less so in the stabilization and de-escalation. The saturation of central venous oxygen, also important during the optimization phase. As also, again, stabilization has been used in stabilization and de-escalation with not such a huge amount of input. Cardiac output, important in optimization, as also fluid, which is why you give rapid fluid boluses, fluid responsiveness, and fluid challenge. The response to that is a meter of the phase of optimization when it really is very important. So these two slides give you the monitoring of fluid replacement during these 4 phases. Now, so what type of fluids? There's been a huge amount of controversy. Do we use colloids? Do we use crystalloids? So this was a Cochrane analysis, and it actually went through 69 studies, 65 randomized controlled trials and 4 quasi randomized controlled trials. And they studied actually 30,000 participants. And the colloids studied were starch solution in 28, dextran in 20, gelatins in 7, albumin or fresh frozen plasma in 22. Each type of colloid was compared to crystalloids, and the conclusion was pretty straightforward. Colloids versus crystalloids probably make little or no difference to the actual mortality. Starches probably slightly increase the need for blood transfusion and renal replacement therapy. It's a moderate to certainty evidence. And albumin and FFP may make little or no difference to the need for renal replacement therapy. And that's a low certainty evidence. So there you are. That was the comparison between colloids and crystalloids. You could use either, and there's a very little difference to the mortality. But if you're using starches, there might be need for blood transfusion, a slightly more need for blood transfusion. Now, if we are going to read about crystalloids, you need to know a bit of history. And this chap in center is Dr. Sidney Ringer. He discovered the Ringer solution in 1882. And, you heard of Alexander Fleming and how he had left the window open and some fungus came in and settled. And lo and behold, he discovered penicillin. Ringer's story was also almost as exotic and, quite exciting. He was trying to get a frog's heart to beat, and he was abysmally failing. He was trying to find the perfect solution. Now, one day his lab technician came in late, and he screamed at him saying, why are you late? And so poor chap, he went in very rapidly, gave him a solution. Sidney Ringer used that and found that the frog's heart was beating beautifully. Guess what? That technician was in such a rush, didn't use distilled water, used good old-fashioned London tap water. And that tap water contained the correct amount of calcium, which Dr. Ringer wasn't putting into his Ringer solution. And therefore, that was when Sidney Ringer discovered his Ringer solution. So you need to know that. It's a lovely bit of history, something very like penicillin. So that was 1882. Hamburger, Dr. Hartog Jacob Hamburger. He didn't discover hamburgers. He developed the so-called normal saline in 1900s. And this American pediatrician, Dr. Alexis Hartman, modified Ringer's solution by adding the buffer lactate in 1932. So three great men, you know, we use their fluids. We use the Ringer solution, we use the Hartman solution, and we use the normal saline. But you need to know a slight bit of the history. It makes some interesting reading. So how do we calculate the fluids? We know the 100-50-20 rules. We've been through that through all the teachings that we use. You use 100 milliliter per kilogram for the first 10 kilograms, 50 milliliter per kilogram for the next 10 kilograms, 20 ml per kilogram for every kilogram over 20. And, you know, that's a beautiful rule. And you can use it for any person any patient you're treating. And the daily requirement of major electrolytes was as follows: sodium 1 to 2 milliequivalents per kilogram per day. Potassium was 0.5 to 1 milliequivalent per kilogram per day. Chloride 1 milliequivalent per kilogram per day. Calcium 2 grams per day. And magnesium 300 milliequivalents per day. It's something that we often forget, and particularly leading to this fancy thing called the refeeding syndrome. Now, you remember that I gave you an estimate of fluids. That was basically when we were going for the examination. This is the actual postgraduate stuff. So I'm going to compare it with plasma. So if you look at plasma, the osmolality is 288. That's your reference. Sodium is 140. Chloride is 103. Potassium is 4.5. Magnesium is 1.25, calcium is 2.5. This was what Ringer was forgetting in his solution that he was trying to prepare. The buffer is in plasma is 24, and it depends on bicarbonates and hemoglobin. So hamburgers, normal saline. Osmolality is 308, so up to 310 is normal, so it's isotonic. And we know sodium and chloride is 154, and there's no buffer. Ringer lactate, Hartman solution, 279, so it's hypotonic because 280 to 310 is the range. Sodium is 130, chloride is 111, potassium is 4, but calcium, remember, Ringer discovered that tap water, London tap water had the correct amount of calcium, so 2.7, and the buffer was 29, and the 29 was used that Hartman used was acetate. Now, these are the two new solutions which are increasingly being used internationally. I think we've also had Plasmalite coming in. I haven't seen Sterofundin at CMRI, but then I've seen Plasmalite. 295, so it's isotonic. You notice that this is very close to plasma. 140, 98, 5, 1.5, but it doesn't contain any calcium. And the buffer, they use two buffers. They use acetate and gluconate. And Sterofundin is the one that everybody is talking about now. That is 309, so isotonic, closest to plasma. 140, 127, slightly chloride more, potassium slightly low, 4, magnesium barely low, but you notice calcium is exactly the same, and they use acetate as a buffer. 5% dextrose, of course, is hypotonic. It's 278, and it contains no sodium, no chloride, no potassium, no magnesium, no calcium. Pure, good old-fashioned water where you are losing water by evaporation. Remember that if you lose water by evaporation, you do not lose any electrolytes. Everything stays back. It's loss of pure water. You might want to replace that with pure water. So types of crystalloids were compared. And if you were using sodium chloride, an excess exogenous chloride administration has been shown to induce the following things. So if you're treating a patient with normal saline, rapid normal saline infusion, remember, that these are the things that can happen. You can have renal artery vasoconstriction. You can have acute kidney injury. You can have a hypochloremic metabolic acidosis. You can have gastrointestinal dysfunction. You can have secretion of inflammatory cytokines, and that has been, it's a fairly recent from 2016, particularly from the intensive care unit. All the intensive care journals have been talking about this. The commonly cited concern about the use of balanced salt solutions is the risk of hyperkalemia. If you're using a balanced salt, like something like Hartmann's, or if you're using sterofundin or plasma line, see, I mean, the potassium is very low, 4 to 4.5 maximum. And the risk, the theoretical risk of causing hyperkalemia. However, when you actually compare evidence, it has been largely invalidated. This suspicion was invalidated and indicated that the metabolic acidosis, which ensues after large volume sodium chloride normal saline administration, may instead trigger extracellular potassium shift. Alkalosis drives potassium into the cells. Acidosis drags it out, and you actually have hyperkalemia due to sodium chloride infusion. So remember that, that hypochloremic metabolic acidosis may cause hyperkalemia. So that is the two crystalloids. On one side, sodium chloride, the other, the balanced salt solution. That was the evidence coming through. So now, blood transfusion. This was, I've taken this from the joint United Kingdom Blood Transfusion to Tissue Transplantation Services. This is the Professional Advisory Committee, and it was very good. So you start off by saying, is the patient anemic and hemodynamically stable? If the patient has more than 9% hemoglobin, the suggestion is do not transfuse. Okay, the patient is anemic, not stable. So you ask yourself, does the patient have either of three things? Does the patient have severe sepsis, have a neurological injury, or does the patient have a cardiac problem? So if the patient has yes, so if it's severe sepsis, is it early or late? If it's early, your target hemoglobin should be 9 to 10 gram%. If there's evidence of tissue hypoxia, if the patient is late, late in severe sepsis, your target should be more than 7. So don't target 9 to 10. If the patient is in neurocritical care with evidence of traumatic brain injury, TBI, traumatic brain injury, or evidence of delayed cerebral ischemia, your target hemoglobin should be 9. If there's subarachnoid hemorrhage, however, your target hemoglobin should be 8 to 10. If the patient has coronary syndromes and ischemic heart disease with falling cardiac output, acute coronary syndrome, the target hemoglobin should be 8 to 9. Patients with stable angina, the target should be more than 7. If, however, the patient doesn't have acute coronary syndrome, severe sepsis or neurological injury, general critical care, use the default hemoglobin trigger of 7. If it's less than 7, transfuse, but your target should be 7 to 9. And I would strongly suggest that you take a screenshot of this. Be less confident using a hemoglobin trigger of 7 if the patient is elderly, though, has significant comorbid conditions like cardiorespiratory problems or inadequate tissue oxygenation. Be more confident of using a hemoglobin trigger of 7 grams if the patient is less than 55 years and if the severity of the illness is relatively low. So be very cautious of overtransfusion. Okay, you've taken a screenshot. If you have, I'm going to move on to the next one, which is equally important from the blood transfusions. So recognize recognize blood loss and trigger major blood loss protocol. Take baseline blood samples before transfusion for a full blood count, group and save, clotting screen, including the close fibrinogen, near patient hemostasis testing if available. What is close fibrinogen. Close fibrinogen is the active fibrinogen. So what you do is you dilute the plasma sample enough to a point that any heparin that you've used or any fibrinogen degradation products which influences the action of fibrinogen is very diluted. And then you test for coagulation. That is tests the activity. The close fibrinogen is the activity of fibrinogen. So near patient hemostasis testing if available. If trauma and less than 3 hours from injury, give tranexamic acid, 1 gram bolus over 10 minutes, followed by IV infusion 1 gram over 8 hours. And if it's non-traumatic, you can consider a 1 gram bolus. The team leader should coordinate management and nominate a member of the team to liaise with the transfusion lab. You need to identify the patient, unique identifier, to limit the use of O negative unless patient group known. You can use O negative units if at a cringe in females, and you can consider using O positive in males. You don't want to start off a D group problem in a female because you never know, she might be of a childbearing age and you don't want to start off a anti-D, you don't want to give her an anti-D. So use O negative for females and O positive in males. Use group specific blood group as soon as possible. Request agreed ratio of blood components, that is, for example, 6 units of RBS and 4 units of FP, and you send the porter to collect the lab urgently. If bleeding continues until lab results are available, what can you do? You can give FFP 1 liter, that is 4 units per 6 units of red cells. You can give cryoprecipitate 2 pools. You can consider platelets, 1 adult therapeutic dose, so ATD, which is adult therapeutic dose. If the lab results are available by the time you are there for transfusion, if the hemoglobin is falling, you give packed cells. If the plasma-thrombin ratio is more than 1.5, you can give 50 of FFP, 15 to 20 milliliter per kilogram. Fibrinogen less than 1.5 gram per liter, you can give cryoprecipitate. You don't have time to do a close fibrinogen out here. Platelet less than 75, you can give platelets 1 adult therapeutic dose. And you continue the cycle of clinical and lab monitoring and administration of goal-directed blood component therapy until bleeding stops. So that is whole blood transfusion. That comes from the British blood transfusion protocol. So one of the problems of overtransfusion is transfusion-related acute lung injury, that's on the left, versus overtransfusion, transfusion-associated cardiac overload. So this is how the chest X-ray looks. It's a central bat swing appearance, which sort of, is more akin to what you've seen in pulmonary edema, whereas this is immune-mediated inflammation in both lungs. Nothing, you can see that the hilum in both are reasonably clear. So the distinction is Trolley versus Tacko. Patient characteristic more common in hematology and in surgical patients. Tacko is more common in patients with over 70 years of age, but can occur at any age. Implicated blood components in Trolley are usually plasma or platelets. Tacko can happen from any component. Onset up to 6 hours from transfusion, usually within 2 hours, and Tacko within 6 hours of transfusion. Oxygen saturation is reduced in both. Blood pressure is often low in Trolley, often high in Tacko. JVP, normal or low in Trolley and elevated in Tacko, and temperature often raised in Trolley and normal in Tacko. So that's how you differentiate between Trolley and Tacko. So if you do a chest X-ray, in Trolley you find bilateral perihilar and nodular shadowing or whiteout heart size is normal. Tacko is you have an enlarged heart and characteristic of pulmonary edema. Echocardiogram is normal in Trolley, abnormal in Tacko. Pulmonary wedge arterial pressure is normal in Trolley, elevated in Tacko. The blood count in Trolley, you have a fall in neutrophils and monocytes followed by neutrophil leukocytosis because this is an immune-mediated attack. So Tacko has no specific changes, particular which is specific for Tacko. Fluid challenge improves Trolley, but obviously worsens Trolley because the problem is you've had a cardiac overload and response to diuretics worsens Trolley, but definitely improves Tacko. So these are the difference, how you differentiate between Trolley and Tacko. So transfusion of blood components, platelet transfusion. So non-bleeding patients without severe sepsis or hemostatic abnormalities, transfusion threshold or target not indicated. Prophylaxis in non-bleeding patients with severe sepsis or hemostatic abnormality, threshold is 20, it's around 2 lakhs, is around 20,000. DIC with bleeding, you have to maintain a platelet of more than 50,000. Platelet dysfunction with non-surgically correctable bleeding, that is post-cardiopulmonary bypass or potent antiplatelet drug, may bleed despite a normal platelet count because this is platelet dysfunction. Transfusion of 1 ADT, adult therapeutic dose, and repeat according to clinical transport. Massive hemorrhage and massive transfusion. Maintain a platelet of more than 75,000, preferably above 1 lakh if multiple trauma or trauma to the central nervous system. So that is about platelets. Fresh frozen plasma, indicator for the treatment of bleeding in patients with deranged coagulation due to deficiency of multiple clotting factors, for example, DIC. Minimum dose is 12 to 15 ml per kilogram, equivalent to 4 units in an average adult. Not indicated for prophylaxis in non-bleeding patients with abnormal clotting tests. This is very important. There's no role for using as prophylaxis. Not indicated for immediate reversal of warfarin, where platelet concentrate can be used. In liver disease, where there's no benefit of FP, transfusion patients with an INR less than 1.7. So fresh frozen plasma. Cryoprecipitate. Adult dose is 2 pooled units. 10 donor units, approximately 3 grams of fibrinogen. Indications include acute DIC with bleeding and fibrinogen less than 1.5 gram per liter. Severe liver disease with bleeding. Prophylaxis for surgery when fibrinogen is less than 1.5 gram per liter, and hypofibrinogenemia associated with massive transfusion, but maintain the fibrinogen above 1.5 gram per liter. Of course, you have categories of shock and their treatment. This is a simplistic view. You've had all the types of shock, and this is basically hemorrhagic and hypovolemic shock where the volume is low. So it can be trauma, can be hemorrhage, dehydration, GI loss, third space as in burns and pancreatitis. So basically it's volume loss. If you have a volume loss, first line of therapy has to be volume transfusion. Where you have a cardiac problem, where there's a pump failure, could be coronary thrombosis, hypertension with global hypoxemia or ischemia, where there's myocardial ischemia. You can have myocarditis or chronic myopathies where you have cardiomyopathy, late hypodynamic septic shock. You can have ventricular rupture and acute valvular papillary muscle dysfunction. You have structural cardiac damage or calcium channel blocker overdose or beta blocker overdose where you have toxic drug overdose. You need a chemical support with inotropic agents. There's no point giving this patient volume. Similarly, if you have a mechanical blockage to forward pump, you can have a pulmonary embolism. We've discussed a cardiac tamponade. We've had tension pneumothorax where there's a mechanical blockage which requires correction of an underlying process of relief of obstructive process. Atrial fibrillation with rapid ventricular response, or a supraventricular tachycardia or a ventricular tachycardia. So it falls on the whole ambit of cardiac arrhythmias. You require a correction of the underlying process or relief of the obstructive process. Early hyperdynamic septic shock, anaphylactic shock, central neurogenic shock, and a toxic drug overdose, where there's a redistribution of extracellular fluid with decreased peripheral resistance. Here you have early volume infusion with chemical support with vasopressor agents as well. Right. Now, these are the pharmacological agents for cardiac support. And just to, enumerate, these are the um, receptor activity. So you might want to take a screenshot of that. Epinephrine works more on alpha 1, also on alpha 2 and beta 1, not on beta 2 or dopamine. Ephedrine works mostly on alpha 1 and beta 1, somewhat on beta 2. Norepinephrine, alpha 1, alpha 2, beta 1, and not too much on beta 2, though some people say they do. Phenylephrine works principally and only on alpha 1. Dopamine is the problem. It works at different doses on different sites. At a low dose of 0.5 to 2 milligram per kilogram per minute, it works more on alpha 2, beta 1, beta 2, and also on dopamine. But the moment you start increasing the dose, there's a shift to the left. You have in 3 to 10 milligram per kilogram, you have more of it working on alpha 1, alpha 2, beta 1, and less on beta 2, also on dopamine. Dopamine stays constant. Um, Dopamine 10 to 20, um, you see the alpha 1 becomes huge, far larger. Alpha 2 stays mildly positive, but beta 1 increases and beta 2 also increases. So dopamine is the bit of a oddball person. It works obviously on dopamine, but then its effect on alpha 1, alpha 2, beta 1, and beta 2 depends on its dosage. Now, temperature control. This is something that is completely, we overlook this. So temperature control in the critically ill. It's not only an important clinical mark of the severity of illness, but also an independent predictor of morbidity and mortality in critically ill patients, which is why nowadays what we do is for all our long, extensive surgery, we insist on putting on a bare hugger. Close monitoring and regulation to avoid body extremes of body temperature is particularly important in the critically ill. And if you look at this range of temperature, 38.6 to 39.5, it has actually the lowest 28-day mortality. And if you look at the unadjusted odds ratio and the confidence interval and the p-value, you notice that that is actually the the best sort of result that you find. Whereas if you allow the range of body temperature to drop lower than 35.5, look at the 28-day mortality. It rises to something like 40, almost 50%. Okay. Similarly, if you go up, it starts increasing again. So that is the narrow confines, 38.6 to 39.5 degrees Celsius, which actually gives you the best value. You have to avoid both hypothermia, which is below 35.5 can be disastrous, and hyperthermia is also bad, but admittedly not as bad as hypothermia. Anything below 36.5, you're looking at 35% or 40% mortality, 28-day mortality. So very important. So if you have fever in ICU, as many as 50% of ICU patients with fever have no apparent infection. Fever is often a sign of inflammation, not infection. Hence, non-infectious causes of fever must be ruled out before subjecting the patient to a number of costly and invasive diagnostic procedures. So what are the non-infectious causes of fever? You have something called a postoperative fever. Fever on the first day following major surgery is reported in 15 to 40% of patients. Procedures: hemodialysis, um, bronchoscopy, blood transfusion, endocrine disorders like thyrotoxicosis, adrenal crisis, myocardial infarction, stroke, and venous thromboembolism. And you have drug fevers. And the common offending drugs are cephalosporins. We're fond of using so many cephalosporins, penicillins, amphotericin B, and phenytoin. All these can induce drug fever. So the empirical therapy for severe sepsis with no obvious focus. I mean, you have ruled out the non-infective causes of uh, fever. So what is the empirical therapy? With severe says no obvious focus. You might choose to use it for patients with indwelling vascular catheters. If patient has received quinolone prophylaxis, if the institution has a high incidence of MRSA infections, if there's a high prevalence of MRSA isolates in the community. And the indications for the treatment with the empiric therapy has to be guided by the dynamic hospital specific protocol. I mean, that particular hospital protocol has to be followed. While you send the blood for culture and sensitivity for both um, aerobic, anaerobic, and fungal. But your empirical therapy would depend on the best guess for that particular hospital. Indications for empiric antifungal drugs are if the septic patient has been neutropenic for 5 days or more, if the patient has had a long-term central venous catheter, if the patient has been hospitalized in an ICU and received broad spectrum antibiotic for a prolonged period. So that is when you would think of an empirical antifungal therapy. Remember that the energy requirement in stress and the energy consumption is 40% depends on causing, your transfer across cell membranes of valuable micronutrients and isolates, potassium, sodium, magnesium, chloride. That 40% is taken up by that, 60% for other reasons. So 40% is the cell uses for maintaining cell membrane stability. How do you assess energy requirements in the critically ill? And indirect calorimetry is the gold standard for measurement of energy expenditure in critically ill patients. And there's an extensive formula. I don't recommend that you try and remember that, but remember that there's a formula for calculating resting energy expenditure. And that depends on the volume of consumed oxygen and the volume of consumed carbon dioxide, produced carbon dioxide. So the ratio is 3.9 into volume of consumed oxygen into 1.1 into volume of plus 1.1 of volume of given off of produced carbon dioxide into 1440. So please do not try and remember that. I've never tried to remember that. All I know is indirect calorimetry is the gold standard, and the resting energy expenditure is calculated by the volume of consumed oxygen and the carbon dioxide, volume of carbon dioxide that is produced. So I think if you remember that, that's great. But do remember this, that the energy expenditure in different phases changes. In the early phase, it's principally carbohydrates, small amount of lipids, very little amount of proteins. As you can see, gradually proteins and lipids through the late phase and recovery phase increase, and carbohydrate requirement goes down. And this famous diagram is given in Schwartz principles of surgery. And you see that the major catabolism and energy requirement is required in major burns, followed by skeletal trauma, followed by severe sepsis, followed by infection, followed by infective surgery, and it is low in partial and total starvation. So that is there in Schwartz. So do have a look. That's given in Schwartz. So in stress, lipid metabolism, what are the metabolism? How do how do lipids, proteins, and carbohydrates, how are they metabolized? Lipid metabolism, is a major source of energy after trauma. Lipolysis is stimulated by sympathetic overdrive, ACTH, cortisol, glucagon, decreased insulin level and effect. Ketones released used by all except brain and blood. Free fatty acid and glycerol undergo gluconeogenesis in the liver for brain and the two substrate in blood that cannot work without glucose. These are RBCs and WBCs. Okay, they cannot work without glucose. Carbohydrate metabolism, high glucagon and low insulin and corticosteroid induced anti-insulin effect. So glycogen stores are mobilized to create a temporary hyperglycemia, which is why what we do in ICU in a previously we used to very tightly control blood sugar in the post-op period. We don't do that now because we realize that his body tries to create a temporary hyperglycemia to enable plenty of food for the brain, RBC, and the WBC. Glycolysis for energy for CNS leukocytes and RBCs, which have insulin-independent mechanism, as I was telling you. But the glycogen stores depletes in 24 hours. Gluconeogenesis from lipid breakdown and amino acid happens after protein breakdown. Protein metabolism. Skeletal muscle releases amino acids. It's an anti-insulin effect. It's also called autocannibalism. If you undergo a very severe trauma, burns, pancreatitis, you notice that the, the muscle bulk you lose muscle bulk. It's a sort of an autocannibalism. You utilize your muscle protein for providing energy. Requirement peaks after about 7 days, often prolonged, proportional to the grade of injury. I mean, if you have burns, it prolongs, you have an increase. That is why I said that anabolic, the flow anabolic phase, which Moore described, is a simplistic view. Sometimes you have an extension of the catabolic phase. Only source if exogenous protein is not provided. Can cause endothelial dysfunction and intestinal mucosal atrophy, loss of barrier to bacterial translocation, and huge amount of sepsis. And a loss of more than 40% is usually fatal. So this is the internal milieu after trauma. It's an anti-insulin internal milieu, as shown by this purple thing. It's the anti-insulin effect. What is the of this? You have an island. The island is the CNS, the island is the RBC, and the island is the WBC, which can use only glucose. So that is a glucose dependent, and it is insulin independent. So it can still continue using glucose despite the relative either lack of insulin or the anti-insulin effect. So what happens is glucose is provided by the liver. How is it provided by the liver? The adipose tissue mobilizes fat, glycerol, and free fatty acid goes to the liver and transformed into gluconeogenesis into glucose. Free fatty acids are acted on by reactive oxygen species. So it is sometimes broken down. From the muscle, amino acids are released. Amino acids also go back to the liver. And in hypoxia, lactate also goes back to the liver. All of this is processed in the liver from gluconeogenesis, all for these three structures. Because don't forget, the rest of the tissues can work on ketones. The rest of the tissue can work without an aerobic, can still metabolize ketones, can still metabolize free fatty acids, but these three cannot. The excess amino acid forms ammonia and urea, and that sometimes gives rise to high ammonia and urea in the body. So recommended macronutrients in the ICU. Energy requirements 25 to 30 kilocalories per kilogram on the calorie or predictive equations. This was the American Society. 25 kilocalories per kilogram by the European Society. So Deepak, when you ask, this is the controversy, you know, there's some bit of controversy, but it's not much of a controversy. 25, if you remember, 25 kilocalories per kilograms, both by the American and the European Society of Nutrition, they sort of, you will still keep both these people happy. Protein is what the European group suggests is 1.3 to 1.4 gram of protein per kilogram. Glucose is a minimum of 2 grams per kilogram, also by the European. Fat and lipids, 0.7 to 1.5 kilograms by the European, 0.8 to 1 gram by PENG, which is the UK group in sepsis and SIRS. So this is the American Society, the European Society, and PENG is the British Society. So this is the critical care programs. But if you remember these things, that utilization of energy source in the various phases of critical illness, endogenous in acute is maximal, it reduces in the late phase, and recovery most. So please remember, you do not need to provide exogenous nutrition in the acute phase. So that's minimal. All is provided. I mean, the huge amount of glucose outpouring happens in an acute phase. So please do not provide nutrition in the acute phase. It's only when you are reaching the late phase, the ebb phase of catabolism, or even the anabolic phase, that is when you increase your exogenous nutrition requirements, and that can then body can utilize it. It cannot utilize, if you provide exogenous nutrition during an acute phase, the body cannot utilize it. So just remember that. That's one of the most important things. So what are the requirements for total parenteral nutrition? For example, fluids approximately 30 milliliter per kilogram per day, calories 25 to 30 kilograms per kilogram per day, protein 1 to 2 gram per kilogram per day, sodium 1.1 to 2 millimoles per kilogram, and potassium 0.5 to 1 millimole. Calcium is 0.1 to 0.3 millimoles per kilograms per day. Magnesium, we remember I told you 300 milligrams, or 0.1 to 0.3 millimoles per kilograms per day. And the energy, approximately 30% should come from lipids and 70% from carbohydrates. For what is refeeding syndrome, and this is very important. You often get asked this, and this can come when if you revert back to your original thing, this can come as a 10-mark question as well. Refeeding syndrome is a life-threatening condition which encompasses acute micronutrient deficiencies, fluid and electrolyte imbalances, and the disturbance of organ function and the metabolic regulation that may result from rapid, over-rapid, or unbalanced nutrition support provision to a malnourished patient. And what happens is severe hypophosphatemia, fluid balance abnormalities, acute overload or depletion, hypokalemia, it goes into the cell, hypomagnesemia again drives into the cell, altered glucose metabolism, a vitamin deficiency, cardiac failure, pulmonary edema, and dysrhythmia, and risk of death. So please remember, phosphates, potassium, magnesium go down. There's a fluid balance abnormality, could be overload or depletion. There's an altered glucose metabolism. There's a vitamin deficiency, and all of this together can affect the heart. You can have cardiac failure, pulmonary edema, and dysrhythmia, and even death. So please remember that. So the mechanism behind refeeding syndrome: when feeding is recommenced after a period of prolonged starvation, which could be as short as 5 days, the insulin level rises. There's intracellular shift. Don't forget that this is a phase that your insulin resistant phase has gone. You're no longer in the insulin resistant phase. So now the insulin level rises, and there's an intracellular shift of potassium, phosphates, magnesium, reduced, and you have reduced extracellular levels. Hypophosphatemia causes severe neuromuscular and cardiovascular dysfunction, seizures, renal, and even hepatic failure. Hypokalemia and hypomagnesemia, neuromuscular and cardiovascular dysfunction, and hyperammonemia, because don't forget, you remember that amino acids don't all get transferred to the liver for glucose, don't all get absorbed for energy. A bit extra can lead to high ammonia. So you have hyperammonemia that caused by protein degradation muscle as a result of adaptive metabolic mechanism in starvation that causes encephalopathy. Diarrhea. As a matter of fact, people say that if you have a patient who's been starving for longer than 10 to 15 days, treat him in ICU. Feed him in ICU. Don't treat him elsewhere, because you need to continuously monitor his cardiac function. And of course, when you start feeding them, if you're feeding them enterally, you end up with diarrhea, because this is osmotic diarrhea, because the amount of fluid you're preserving, if you're giving too much of fluid, it is hyperosmolar, and hyperosmolar will happen with a hyperosmolar fluid is inside the intestine is it drags in fluid from the rest of the body. So you have a shift of fluids from the extracellular into the intra-intestinal space and diarrhea, but you're leaving the patient more dehydrated than ever before because of that osmotic diarrhea. So how would you manage the refeeding syndrome? So replacement of potassium, replacement of phosphate and magnesium, thiamine and multivitamins. You do a slow start to feed, 25% to 50% target. You monitor electrolytes and build up to a maximum over 72 hours, not immediately, not 24, not 48, but 72 hours, 3 days. Remember that you start feeding them full only after 3 days. And this is what I was saying, that if you have a patient who's come in with a BMI of less than 14 and about 15 days plus of starvation, you have to monitor that patient in ICU for cardiac arrhythmias, right? Okay. This is thoughts for the future. Tailoring metabolic and nutrition therapy in ICU. Perhaps the treatment, you see pre-injury sepsis and trauma, you have a metabolic cart measurement for energy needs weekly. Perhaps they think that a carbon 12 or 13 mass spectroscopy breath test will determine the transition from an acute phase to a chronic phase. These are thoughts for the future. It hasn't come in yet, but they are trying to define whether a spectroscopy of a breath test of the ratio between the 12 carbon and 13 carbon can give you a timing where the phase goes from acute to a chronic phase. So treatment in acute phase, protein, lower non-protein, kcals, beta blockers, thiamine, vitamin D, and probiotics in the acute phase. Calories, protein increased, oxandrolone, beta blockers, creatinine, vitamin D, probiotics. If you can give glutamine if there's no acute kidney injury or kidney injury on chronic renal replacement therapy. And you could start exercise and physical therapy to induce protein buildup in muscles. So that's the chronic phase. And in the recovery phase, calories, proteins, propranolol, oxandrolone, can use target microbiome recovery on exercise used in recovery. So these are unfortunately thoughts for the future. You have to wait and find out whether they actually come to theory. You remember that this was 2016. A number of them have fallen by the way by the time 4 years have gone through. So there we are. So further reading, please go to the references and the short practice of surgery, Bailey and Love, and Schwartz principles of surgery. And I promised, Deepak, I promised you that I'll give you that entire reference. That's a, so these are just the synopsis of various. I'll give you if you want to read up about it, I've given you a synopsis. Now, if you feel up to it, want to read up about it, you have time, I'll be only happy to share this with you. So I've gone through a number of articles. A number of them are actually anesthesia journals and journals of International Journal of Antimicrobial Agents, transfusion medicines, little booklets, Cochrane Library, kidney journal on kidney diseases, fluid therapy. So, and of course, what I've used heavily from is the guidelines for blood transfusion services in the United Kingdom and endocrine issues and critical illnesses. So I've tried to make a synopsis of what one would need in surgery. Of course, if you have any questions.